from this. I really like to learn from questions as well. So if there's any points of discussion you'd like to raise, that's completely fine. The practice exam, I've done lots of questions and then I've changed the order around. So we might be starting with question 7 or something like that. So I apologise. And I've got an answer key for kind of membership level, which I'll just sort of be looking down and ticking off as people talk. But I want this to be as interactive as possible. So you're all going to have to talk and I will prompt you the way that I've been prompted in the oral exams I've done. So is everybody happy to start? Yep.
Hello.
That's good.
Morning, Max.
Hey, good morning.
Oh, Max, where are you?
I'm attending my friend's wedding, so I'm in Brisbane Airport.
Oh my gosh. Wow. Thanks for coming. All right. So let's go. Starting with question 6. Question 6, we have an 8-year-old female neutered ragdoll. She has a 1-week history of reducing appetite, intermittent vomiting, and is now anorexic. On physical examination, she has a palpable big kidney on the right and a little kidney on the left. She has pain on palpation over the right kidney. Her biochemical changes include a urea of 45, a creatinine of 890 with 140, the upper limit of normal, a potassium of 7.5, and a phosphorus of 4.5. Can everybody see my screen?
Yes.
Excellent. Yes. All right, let's start. First question is describe the radiographic changes evident here.
Well, there's a very large right kidney and a small left kidney.
Excellent.
The right kidney looks like it's got smooth margins and it looks like there's some mineral opacity or something in the renal pelvis of the left kidney, unless it's had some contrast agent or something.
Excellent, good. I know there's only a single view, which is not obviously how you'd assess something in a clinic, but often with an oral exam, putting up sequential views is you can't sort of go back and forth. So often you do only get one view to comment on.
There's also some staples that look, they're just off to the left of the spine there, the lumbar vertebrae, which if we're going to make some kind of assumptions, I guess, could be from a previous surgery. Good. Or maybe cutaneous. I guess it's hard to say with this one view.
Haven't examined, yeah. Good, excellent. And there's something else that's not necessarily abnormal, but something that I would like you to point out in a cat with the biochemical and electrolyte changes that we have here.
The bladder isn't overly distended.
Good, it is the bladder. It's reasonable size though, isn't it?
Yeah, it's a bit big, but it's not.
It's not huge. Yeah. Good.
It hasn't got a very nice margin. The margins of the bladder are a little bit rough, really. They're not smooth or regular.
Yeah. Good. All right. So you've got full marks essentially for the radiographic changes that I was after. So moving on to the next component of the question. And I've put the biochemical and electrolyte changes here for reference. But part B, list the causes of unilateral Auranomegaly.
Renal lymphoma.
Good.
Hydronephrosis.
Yep.
Pyelonephritis.
Good, excellent. One more.
I'd better not say too much. I passed my membership 40 years ago, but I'd hate to fail it now.
Something like polycystic kidney disease, would that tend to affect both kidneys and be a younger cat?
Potentially, so they can be completely aclinical. So cystic disease is one of them. Genetic polycystic kidney disease would be bilateral, but a single renal cyst could absolutely cause changes that we're seeing here.
Yeah, okay.
Excellent. So I've covered all of them. Let's go back to hydronephrosis. Now, can you please list a couple of causes of, 3 causes of hydronephrosis?
Transitional cell carcinoma that's obstructing the ureter.
Good, excellent.
And a ureter.
Ureter, excellent.
Yeah.
Yep.
And something else?
Secondary to pyelonephritis, like we just have a lot of inflammatory material.
Absolutely. Yep. And on that, sorry, I shouldn't be prompting as much.
Eye treatment.
We'll say again, Matt.
Eye treatment from surgery.
Oh, excellent. Good.
Sorry, I didn't hear that.
Iatrogenic, you said, from surgery. So
okay.
That's got staples in there. That's a really good point in this cat, whether it's been desexed recently or something like that. Okay, and the other ones I had on my list, which I've got 2 answer keys. I've got a fellowship and a membership one. So you guys have covered the membership one. But there's also a syndrome called Circumcable Ureters. I don't know if anyone's heard of them. And they're in the right kidney of 30% of cats, where the ureter actually dives up and over the cava, which just causes a kind of extramural compression of the ureter. So if you then get a pyelonephritis and the flow of urine is sludgy, it can cause an obstruction. Or if you get a stone that's trying to pass, it's less likely to pass if there's a circumcable ureter. Stricture is another one. So we sometimes get stones that pass, but the inflammation they cause where they lodged in the first place can cause a stricture. So you don't actually have a stone there at the time, but you've got an obstruction there. And the other one is associated with idiopathic renal hematuria. And it's actually a blood clot that forms in the renal pelvis and turns kind of into a stone, and it can get stuck in the ureter as well. So that I would put under my category of urolithiasis, but it's technically not a urolith. So at a fellowship level, I'd expect a bit more detail than that. But you guys got all the membership ones, so very good. Now, question C, describe your initial stabilization and management of this patient.
For initial stabilization, what I would want to do is also firstly try and find out if the urethra is patent. So I'd want to place a urinary catheter. The other kind of main concern I would have would be with the potassium being quite high as well. So I'd want to also approach that, which might include starting some glucose supplementation to try and drive the potassium back into cells. Yeah. If we needed to do sedation to put a catheter in, I might also consider something like calcium gluconate as a cardioprotective mechanism before sedation as well. And then move towards trying to figure out why we've got such a big kidney. So things like abdominal imaging with ultrasound, and then kind of go from there.
Excellent.
I'd also start IV fluids as well.
Okay. At what rate would you start off with?
I'd probably start at the moment with maintenance, so like 2.5 mils per kilogram, and just make sure we're not completely obstructed. And if we are, then trying to resolve that, depending on where that is happening, if we can sort that out with an ultrasound or urinary catheter.
So you've sort of now alluded to it, but what is the main thing you're going to be monitoring once your urethral catheter is in place?
So urine output.
Mm-hmm.
So how many mils per hour that this cat's producing would be one of the big ones, because it definitely could be, and most likely will be, acute renal injury with that right kidney, or it maybe not be functioning at all.
Excellent.
I'd also want to get a urine sample and send that away for culture and urinalysis.
Good.
Well, both kidneys must be malfunctioning because to cause the uremia, because they can work fine just on one.
Yeah, so the left kidney probably does have some chronic changes.
Absolutely. So all the more important to try and do everything we can for that right kidney. Okay, you give a glucose bolus. This cat's blood glucose is 22 and the potassium remains at 7.2. What else can you do?
You can also give insulin. Oh, sorry.
Good. Excellent, Grace. Good.
So you could give an Act Rapid bolus, subcut, not bolus, and then put them on an Act Rapid CRI.
Yeah.
I can't remember the rate.
That's fine. Josh, I stitched you up because you work with me and you know I don't do that with insulin, but you should mention it in an exam situation. So you've...
The other thing you could do is put an ECG on it because, I mean, the heart should be malfunctioning at that level of potassium, but knowing whether it is or not, the science is knowing that it should be and the art is knowing is it.
Yeah. This cat was not bradycardic on initial assessment, but I think continuous ECG and continuous heart rate monitoring is indicated in this patient for sure, particularly if you're using sedations and things. Where are we up to? Okay, fluid rate of 2.5 initially with adjustments based on urine output. I really liked that, Josh. That was excellent. We've just missed an easy mark based on our physical exam and our knowledge of how people report it feels to pass a kidney stone.
Oh, we need to give it pain relief.
We need to give it pain relief. Absolutely. Don't miss the easy marks. Yeah. What pain relief would you choose?
Buprenorphine.
Good.
What was that? Sorry.
Now, is there any reason why we might be going to surgery in this cat?
If it's got a unilateral or a right-sided ureterolith, you could look at placing a sub.
Good.
To relieve the obstruction.
Good.
Which is probably quite important given that the left kidney is very small and potentially not particularly functional.
Yeah, we need to get in pretty quickly as soon as the cat's stable if the owners want to go down that route or if it's a candidate for it. Okay, so on your ultrasound, you do see a ureterolith in the proximal part of the right ureter. You see a profound hydronephrosis associated with that. And the left kidney is small with decreased corticomedullary distinction and a dilated renal pelvis, and several nephroliths in both the ureter and the renal pelvis. What is going to be your recommendation to the owner?
So the both side of the ureter got stone, did you say?
Yes.
I think I recommend to do both sides.
Just put a sub in.
Yeah.
Yeah. Give me detail, Max.
Well, I think like now the creatinine is 880. That means both kidneys not functioning.
Good.
But if the left side is still patent, then I think we should salvage whatever we have to do both sides up. But obviously, when we do this kind of procedure, we do induce certain level of kidney injury.
Good.
Then the creatinine may go up, and there's other complication with the subcutaneous urethral bypass catheter as well. So I think the owner need to know.
Good.
And ongoing management. That's the problem. Yeah.
Ongoing management and complications. Now, is there, other than pain relief, are there any other medications? So owner declines subplacement. What options do we have for medical management of this patient to assist with passing its ureterally?
Prazosin, it's something that you can try.
Yeah.
I think that's or like diazepam, that's something that you can try, but I don't think there's anywhere they're saying that it works.
Yeah.
Is the musculature of the ureter, is it smooth or striated muscle?
It's smooth. It's similar to the urethra, but with less alpha-2 receptors, I think. Am I getting that wrong? So in theory, things like prazosin should work with ureteral dilation, but the clinical studies that have been done show no difference in outcome with the use of prazosin or not. But the theoretical benefit is there and the risk is low in these patients. So we typically do use prazosin.
Diazepam shouldn't work if there's no striated muscle.
It shouldn't work, but it does relax the patients. So there's no evidence to say it actually improves the ureteral function or helps pass the stone at all. But I think these patients need to be sedated if they've got any chance of getting through it. So I think midazolam's a good choice of sedation just in case. And also with a urethral catheter in, it's nice to have a bit of muscle relaxant on board. All right, so you've pretty much got all the marks there, but my only advice for you all is to just make sure that you think through. The first thing I do, Josh, you mentioned sedation. In that, just say detail. So my sedation would include a pain relief component for this cat, given the condition it has or something like that. All right, should we move on to question 2, or does anyone have any questions about that one?
Would you, in that scenario, would it be worth saying that, in an exam setting, mention that euthanasia is not the wrong thing as well, or is that worth even mentioning? Or?
It absolutely is, because if this cat gets through this, it's going to have some degree of permanent renal damage. We know that one of the kidneys is probably not functioning and the other one is in dire straits. So yeah, I didn't write it down, but that's absolutely appropriate. And you should mention it. Good point. Okay, this is, you'll find in a lot of the oral exams and stuff like that, they give you a breather question. So this question is one that I got a lot, which I found really annoying, but it's good to just get in the practice of answering it. So question 2, the 6-year-old female neutered domestic short hair presents for lethargy, anorexia of 3 days duration. A grade 2 out of 6 right parasternal murmur is audible with a gallop rhythm. The respiratory rate is increased at 60 beats per minute with restrictive respiratory pattern. The remainder of the historical and physical examination is normal. A, make a problem list.
Tachypnea, the gallop rhythm, 2 out of 6 heart murmur, restrictive respiratory pattern.
Yeah.
And the anorexia.
Good. Excellent. So this is one, they just kind of give you marks sometimes. This is one don't miss anything. B, list your ideal diagnostic testing plan for this patient.
So you probably want to start with some blood testing. Or would you ask history first? Would you say that here?
Well, I absolutely would, yeah.
Yeah, so collect a full history to see if it's an indoor, outdoor cat, if it's had any access to toxins, what its diet is, those kind of things. If it lives with other cats, if it's had something like this before. Then moving into more kind of blood testing. So I'd want to do a CBC and biochemistry. Ideally get a urine sample for urine analysis as well. Then based on, or then from there, probably move on to an echocardiogram to examine the heart, as well as perform some thoracic radiographs. You could also argue that we might benefit from an ultrasound, but we might be getting some abdominal ultrasound, sorry, based on the anorexia. But I think I'd wait until I had those first tests first before I kind of recommended that.
I think my first move would be to put a pulse oximeter on it and assess whether it needs oxygen supplementation, and then an ultrasound, like a T-fast, because there's a reasonable chance this cat's got pleural effusion of some description that might need tapping, and tapping it would relieve the respiratory distress to a large degree. And then go for the other diagnostics.
Excellent, good. So that's first answer. Any patient that you do a question on where there's any question of respiratory distress or anything that is potentially life-threatening, first answer is stabilisation of the patient and assessment of oxygen levels and anything that might need to be stabilised before the diagnostic tests are done. So like pleural effusion in this patient is excellent.
So you might want to mention sedation as well.
Yeah. That I wouldn't be able to put sedation in my answer key because it's not part of my ideal diagnostic testing plan, but certainly pulse ox and T-fast are really good things that we can do without sort of sedation or positioning, and get a better idea of what's going on. Like they are diagnostic tests.
Yeah.
But I would certainly sedate this cat if it was distressed. But all of that, and then I would do all of the tests that Josh wanted to do as well. When you're taking your blood samples, you mentioned hematology and biochemistry. Do you want to do any other tests?
Can we do a T4 as well?
Great.
Do we need to justify that?
No, I would probably at this point, if it says describe your ideal diagnostic testing plan, absolutely go into detail. Okay. But list is just, you don't have to do too much. Yep. Anything else on your blood?
Blood gas, like blood gas.
Excellent.
Could you run a pro-BNP?
Yes, I do. I really do. Yeah, good. Excellent. All right, so that's pretty much all I do. That's everything on my list for the ideal diagnostic plan in the initial phase of managing this patient. So we did end up taking some radiographs. This is a right lateral. A left lateral. And the DV. So I'll leave those up there. So we've got the left lateral and the DV up there. And question C is describe the radiographic changes here.
I think subjectively, on the left lateral, the cardiac silhouette looks enlarged, but you'd have to do a vertebral heart score. And certainly on the DV, there's increased opacity within the lung fields. I'm assuming alveolar, but it's a bit hard to tell.
Good.
Yeah, it's quite tricky. I don't know if it's just the detail I've got on my laptop, but the one thing that I can kind of see is, well, two things. It does look like there's a bit of a diffuse bronchial pattern. I can see kind of, thickened bronchial walls, but on the DV, it's kind of tricky, but it looks like maybe the vessels are enlarged as well.
Good.
I think they're both, like the main one, looks like both the arteries and the veins maybe look enlarged to me.
Yep.
So that doesn't really help with me to trying to define whether it's airway versus cardiac as a cause. That's where I'm kind of having trouble.
Excellent. Anything else you can see on these radiographs?
Looks like there's quite a bit of gas in the stomach as well. It's probably stress-related aerophagia.
Excellent.
And the liver margins extend quite past the costal arch.
I thought so too.
And there's quite a lot of intra-abdominal fat as well below, I guess, which maybe just normal. Yeah.
There's a nice angle at the bottom of them, but it does, the stomach to me does it like this, the angle of the stomach does appear to be somewhat more tilted than it should be.
I agree. Excellent. I thought when I initially looked at these radiographs, I thought the lungs might be a little bit overfilled, sort of hyperinflated. And I don't know whether that's just a true deep inspiratory shot and both laterals and the DV were very well timed, or if this cat does have a little bit of hyperinflation of the lungs, which might indicate bronchial disease. The radiologist didn't agree that it was hyperinflated at all, but I've got that in my answer key just because first impressions, I think that's a reasonable assessment, but that wasn't worth any marks. That was just my sort of observations. But you guys got all the other things on my answer key. As far as sort of differentiating between bronchial, interstitial, alveolar pattern, there's very limited agreement even amongst radiologists of naming the pattern. So I often, in an exam situation, I would often say there's increased opacity throughout the entire lung fields diffusely. It's not a nodular pattern and I can't differentiate between, it looks more than just bronchial, but I can't differentiate between bronchointerstitial or interstitial alveolar in this situation, which I think is like no examiner's going to expect you to be able to do that if radiologists can't agree on it. Okay, there's a lot of information on this slide. Sorry, everyone. So we did do an echocardiogram. The left atrium was 19 millimeters in diameter with 15 millimeters the upper limit of normal. So there was left atriomegaly and an LAAO ratio of 2.1. On M mode, there was evidence of ventricular wall hypertrophy with the interventricular septum being 8 millimeters with an upper limit of 6. And the free wall, the left ventricular parietal wall in diastole being 7 millimeters with an upper limit of 6. There is a focal hypertrophic lesion in the septal wall at the left ventricular outflow tract with hypertrophic endocardium overlying. There is turbulent flow through the aortic valve, which is increased in velocity at 2 meters per second. There is no systolic anterior motion of the mitral valve seen. So I'm just going to leave that information up there, and these next 4 questions kind of relate back to that. So D, the pro-BNP is elevated. Can this cat's respiratory distress be attributed to cardiac disease on the basis of the information we have now?
Yes.
Yes, I agree. So this cat's congestive heart failure due to HCM would be my working diagnosis. List the causes of myocardial hypertrophy in the cat.
Hyperthyroidism, the renal disease, idiopathic hypertension, I can only think 3, or genetic. I don't think diet can cause problem.
I don't think so either.
Heartworm.
Good.
So I got 5.
How does heartworm cause ventricular wall thickening?
Increasing pulmonary arterial bed pressure, so pulmonary hypertension.
Okay. Will it cause left-sided hypertrophy?
No.
No. Good. But same mechanism of increasing outflow pressure?
Like chronic airway disease.
No, actually, we're talking about the left side of the heart being hypertrophic. So outflow of the left side. That's unrelated to respiratory.
Aortic stenosis.
Excellent.
Yeah.
Good. So it's really rare in cats, but definitely happens. And in this cat, had that focal lesion in their left ventricular outflow tract, which was causing a relative stenosis and increased velocity. So that's probably contributing to its the hypertrophy. That was good. That last part was fellowship level, and there's a couple more. There's one more that I would allocate half a mark to in at membership level.
Would that be neoplasia? But then again,
Good.
yeah, that can be diffuse. Yeah.
It absolutely can. Yeah. So infiltrative myocardial disease, so lymphoma. Excellent. And then growth hormone, hypersomatotropism. But they never, like, it's just an incidental finding in those cats. They always present with their diabetes and Cushing's disease and stuff. So that's not something that it wouldn't present like this cat if that was the case. Okay, good. So question F, list any additional diagnostics you may want to complete in this patient. We've already done our T4, normal.
Blood pressure.
Excellent. That's all I'd expect from you guys. The 6 marks was the fellowship one. Sorry, that's great. Okay, describe your approach to treatment of this patient, justifying your treatment choices.
If it is hyperthyroidism, then we should control the thyroid level with the medication or I-131. If it is idiopathic hypertension, then we control the blood pressure with the calcium channel blocker like amlodipine. If there's sign of kidney disease, I think you can use ACE inhibitor. If it is like, as she said, like growth hormone problem, then you can use somatostatin for that.
What
I don't think that yeah.
Sort of going back to like what you'd feel in a clinic with a patient with congestive heart failure presented, go back to sort of first your easy marks.
Like a diuretic medication.
Yeah, absolutely. Yeah, good. Thanks.
Like oxygen therapy.
Good.
If I answer pimobandine, this answer, I don't think that's right because I think they prove that it's not going to make a difference.
It's probably controversial. So there's cardiologists that use it and there's cardiologists that don't. So, for example, Rita uses it with fixed obstruction, but not dynamic obstruction of the outflow tract. So if there's SAM, she won't use it, but she will use it in other HCM cats. But what about sedation in this cat?
Maybe just some butorphanol.
Good. Why? Why is that your choice? Sorry.
I just want to slow down its breathing and calm it down and not exacerbate its congestive heart failure anymore.
Good.
Something light.
Yeah, awesome. So we don't want to give anything that's going to impact like contractility or heart function. So they were bound by a few of the medications that we use for sedation. We want to get good sedation effect without compromising the cardiovascular system. Sorry about my dogs. And butorphanol probably has the best sedation effect of the opioid medications. The idea of sedation is decreasing the oxygen requirement of the body. So you don't want them moving around too much. You don't want them anxious. So they're the two things you want to address, because obviously anxiety increases adrenaline, increases oxygen requirement, which increases respiratory rate. So butorphanol would be my choice, absolutely. There's also, I mean, you could use other opioids as well, but butorphanol and morphine both selectively dilate the pulmonary vasculature, which just means there's less pressure in there and therefore there's less fluid leaking out of there into the alveoli or interstitium and alveoli. So I think opioids are a really good choice, and you could use something like midazolam in addition if the cat was particularly stressed. Furosemide, max covered. Pimobendan, controversial, but I'd probably say, I know that some specialists use pimobendan. In this case, I would seek the input of the specialist who did the echocardiogram. And there's one, given the size of the left atrium, there's one sort of class of medication that I want you to talk about.
Clopidogrel?
Clopidogrel, did you say?
Yes.
Good, excellent, absolutely. So any LAAO over 2, I send the patients home on clopidogrel because they've got a high risk of aortic or any thromboembolic disease. I'm really sorry about my dogs. It's party time, apparently. All right, that was a really hard question. Thanks for bearing with me on that one. All right.
Sorry, with that question,
sorry?
So with that question, as I remember initially, you said got a restrictive breathing pattern.
Yeah.
In exam situation, can I ask like what sort of restrictive breathing pattern, like expiratory or inspiratory?
Yeah, absolutely. So you can ask for more detail on anything, and the examiners like that because you can't possibly put everything down on the page. So absolutely don't be shy about asking questions about the like more detailed history, like where are we in Australia, for example, is a good one. Like if there's potentially infectious diseases and stuff like that.
I had no idea you could ask questions. That's great.
Absolutely, yeah, for sure.
Right.
And particularly if they say like discuss your approach to this patient or something like that, I would seek more historical information, such as has it had blood tests before in its past, or determining chronicity of different changes and stuff like that. You definitely can. And it's more, they keep it, like I'm actually being quite harsh with you guys, like pushing you on questions. They're going to be much friendlier than I am. They're like, both of my oral exams I was heavily pregnant for, which is a bad idea. But I'd like lost my vocabulary and I was just trying to describe the biliary tree because I couldn't remember the word cholangitis. And I was like drawing pictures of trees for the examiners and they were laughing their heads off at me. So they expect people to be a bit dysfunctional in this situation. don't worry about it.
2 comments. One, I thought that was a function of old age only. And
Pregnancy too.
and secondly, my fellowship exam asking, well, actually, they gave me the geography. They told me it was a dog from Lincolnshire that had respiratory problems.
Mm.
And I knew Lincolnshire was a rural area, and I also knew that paraquat was a herbicide that British farmers used. Yeah. So the geography gave it away. Plus the research on the examiner's publications.
That's a hot tip. The next one, we should do journal club on your examiners. That's actually a really good point, Jeff. There is no superfluous information in the questions. If they put sex, breed, that everything is a hint in there. If they put location, it's a really big hint, and start racking your brain as soon as you start reading the question that it's going to be something to do with what's going on. So for example, let's skip ahead actually. Okay. Let's do this one. So a 2-year-old female entire poodle cross presents to you at your clinic with a short-term history of gingival bleeding. Describe your initial approach to this case.
Thorough physical exam.
Very good.
Looking for other bleeding, bruising.
Excellent.
Like if there's any sign of dental disease.
Yeah, excellent, good. I didn't have that on my answer key, but I should have.
I miss what a colleague said, but geography would be important here because the questions of have you been travelling lately, like in other words, Northern Territory or Northern Australia, and the other thing was just west of the Great Divide at the present time with the mouse plague.
Excellent.
And if it's a city-based dog and hasn't been out of, the question I'd ask them, the indirect question is, do they have any trouble with rats or mice around the house?
Excellent. So this question originally said, 2-year-old female entire poodle cross in the Northern Territory presents to you in your clinic in the Northern Territory with a short-term history of gingival bleeding. But at membership level, I really want you to say, I would ask for historical information about the location that this patient has travelled to. So I took it out. Well done. Physical examination, excellent. So there are petechiae over the rest of this dog. What next?
Blood testing. So you can do a CBC to check for anemia as well as platelet count. Mm-hmm. I pair that with a blood smear.
Yeah, good.
I'd also perform coagulation testing for PT, APTT, biochemistry as well. Then we can send off for things like more specific kind of infectious disease testing, so things like leptospira PCRs and also Ehrlichia PCR, and also maybe serology at the same time for both.
Yeah.
Does the dog have a temperature?
It does. But it's a 2-year-old stressed poodle.
So also baseline cortisol.
Excellent.
Maybe a stim, depending on that.
I think you can never go wrong saying baseline cortisol for a stim test. What about, I think you said biochem. Did you say biochem? Yes, good. Sorry, I just was taking notes. How are you going to collect your blood? What precautions are you going to take?
So either peripheral stick, or if you do go, I'd probably just go peripheral stick. But if I went with the jugular, I'd hold it off for like 5 to 10 minutes with a pack of swabs.
Yeah, excellent. So as a guideline, just what I usually do, if it's bleeding in one location, like just gingival bleeding, and they've got dental disease and there's no other petechiae, ecchymosis or evidence of bleeding, I will go a jugular stick, because you get a much more accurate platelet count from a jugular stick. But I will hold it off for 5 minutes. But if there's evidence of bleeding in multiple locations, I'll always use a peripheral vein just for safety, because we can put a Band-Aid on it and leave it on for an hour. Something we didn't do in our physical exam or our historical checking regarding feces.
Like a rectal
Check
exam.
for melena.
Yeah, exactly. So checking for melena, whether it's by a rectal exam or via the owner's description of the feces. And Josh said tick-borne disease titer testing. You mentioned lepto and Alecia. I'd like you to do another one.
Alecia as well? Or
Good.
no?
And
Anaplasma?
good, excellent. The anaplasma is the one that can just cause a thrombocytopenia. So very, like babesia causes anemia, with anaplasma is more likely to cause thrombocytopenia exclusively. And Alecia they're all thrombocytopenic, as we talked about. What about urine?
Worth testing, especially if it is something like a thrombocytopenia that you're suspecting to be immune mediated. You want to get culture results.
Exactly. How are you going to collect it?
Either hopefully a free catch, I think, would be safer.
Cool.
I don't think a cystocentesis would be a good idea in this patient.
Good.
You could use a urinary catheter, I guess, but that could be a bit more traumatic as well, and probably not a great idea either.
Excellent. Good. So you've got everything on there. Just with your kind of testing, I sort of, in the US, they've got this minimum database, and it's hematology, biochemistry, urine. Just put it in every answer. Essentially, you're not going to get it wrong for putting too much, like doing too many tests, but you will not get marks if you don't say what's on the answer key, for example. And specific, like if we're dealing with an IMTP, for example, you do want to definitely have a urine culture, urinalysis and culture to rule out UTI. So history, this dog has a history of having gingival bleeding previously when it was teething. She's an entire female, and she's had heavy bleeding during estrus, but has never had a litter. She's had no prior surgical intervention. Her physical examination reveals pinpoint petechiae on mucosal membranes of the oral and vaginal cavities, but no echymoses, and her vitals are within normal limits. Her urea is marginally elevated at 14, but the biochemistry is otherwise normal. On hematology, her MCV is low normal. Her red blood cell count is normal. She's not anemic. And her platelet count is normal at 340. She has no evidence of systemic inflammation in white blood cells or a stress leukogram. Her coags were normal, but you did do a buccal mucosal bleeding time, which was prolonged at 300 seconds. Tick-borne disease testing was all normal. So section B, list the remaining possible causes of this dog's gingival bleeding. 2 marks, so you want to do 2 answers.
Thrombocytopathias and von Willebrand factor deficiencies.
Very good, Josh. I'm so proud. Section C, vasculitis, like I would have taken a mark for vasculitis, but it's very unlikely to have such a well dog with no evidence of systemic inflammation. So they're the 2 for sure. So question C, describe how you'd investigate this further. This is a fellowship question, so I don't expect you to get 6 marks. I would like you to do 2 marks.
I think iron studies could be useful because of the microcytosis and the chronic bleeding. It may be heading towards iron deficiency, though it's not anemic yet.
Mm-hmm.
It's not a major thing. I'll leave the rest to the others.
Some sort of von Willebrand's factor testing.
Excellent. Good. And there's one more. Does anyone know what tests are available to test platelet function?
So thromboelastogram, no, that's more for platelet breakdown, isn't it? I've never run one, sorry, I'm not sure.
No, that's completely fine. Thromboelastography is kind of this new emerging way of looking at platelet function, and Sydney Uni are doing it. So that's the only reason I sort of said, like, I would not expect you to get this in an exam setting, but it is available to us clinically as clinicians locally. If we need platelet function testing done, Sydney Uni can help us out with thromboelastography. So von Willebrand's factor testing is the main one we want to do. 2 different ways of doing that. You can measure the activity of von Willebrand's factor, or you can measure the level of von Willebrand's factor. And we probably want a combination of both of those because of the different types of von Willebrand's factor. You can have like a normal amount of von Willebrand's factor and have it very dysfunctional because the strands of von Willebrand's aren't long enough. So you want to know how active it is and also what factor, at what level it's at. So results, platelet function testing was unremarkable. Von Willebrand factor levels were low. Von Willebrand factor activity levels were also low. Ignore the genetic PCR being normal, that's a trick question. What is your diagnosis?
On Willebrand's factor deficiency.
Excellent, very good.
1 or 3. That's
excellent. Describe your approach to management of von Willebrand's factor deficiency. Don't worry about explaining the mechanism of action.
Desmopressin.
Excellent, very good. Do you actually know the mechanism of action?
It's got something to do with putting more von Willebrand's factor into circulation from the endothelial cells. I'm not sure if that works, but
yeah. Excellent. So essentially just makes so von Willebrand's factor comes out of the endothelial cell and then gets snapped off at whatever length it's kind of genetically coded to be snapped off at. And the longer it is, the more platelet it catches. Like it's like a big net versus a little net sort of thing to catch platelets. So desmopressin favors large multimers, so long strands of von Willebrand's factor. So the von Willebrand's that comes out is more effective. So particularly if you need to do any surgical procedures or any intervention, desmopressin's a good thing to do half an hour before, only lasts a few hours. But in a patient that's actively bleeding, is there anything else you could do?
Plasma transfusion.
Good. What sort of
frozen plasma? Fresh frozen plasma.
Good, excellent. So make sure it's fresh frozen. Yeah, it's got to be fresh. It can't just be frozen plasma. Von Willebrand's degrades very rapidly if it's defrosted and refrozen. Good, very, very good. Okay, what have we got? 4 minutes. Quick sticks. 13-year-old male-neutered domestic short hair presents to you with progressive weight loss over 3 months, a 3-day history of anorexia. On clinical examination, the cat has a ventral symmetrical alopecia with smooth, shiny skin where hair loss has occurred. The region is non-pruritic with no evidence of inflammation. Hematology and biochemistry are normal. List your top differential diagnoses for this cat's condition.
Hyper A.
Good.
That's the only one I think of.
Sorry, I missed that last part.
Oh, so sorry. I was just saying I can't think of anything else either. Sorry.
Can it be paraneoplastic alopecia?
I'm so proud of you.
Oh, thanks.
Very good. So hyper A, we would expect some biochemical changes, but I definitely would accept that, absolutely. So that's one of the differentials. This type of alopecia in cats with no biochemical changes is most consistent with paraneoplastic alopecia, and cats do paraneoplastic differently from everybody else, but they get this really distinctive shiny skin. So this is a question that I put in the oral exam. I would never, as an examiner, allocate more than 1 mark to a question that is so specific. And like, you know, if you haven't seen it before, or if you haven't read that, I would never make you kind of go into more detail about it. But so the most common neoplasia that it's associated with, do you know?
So biliary carcinoma.
Excellent. Yeah. So pancreatic or biliary, hepatocellular rarely, but carcinoma of the kind of pancreas and biliary system. So describe your diagnostic approach to confirm your suspicions.
I'd pull out my ultrasound and have a look at that pancreatic biliary area.
Good.
And I would discuss an F&A, I guess, with the owner, but carcinomas don't like to exfoliate their cells terribly well. So I guess if they're motivated clients, I talk to them about biopsy.
Good. Excellent. So as I said, that's just a quick one. So that's going to be our last question. You guys did really well. The main thing with oral exams is just not missing easy marks. So make sure you're covering like stabilization, pain relief, and your minimum database in every kind of diagnostic testing question. You'll do great. What date's the exam on?
Mine's the 20th.
Yeah, I'm 20th as well.
21st.
Your 21st, Max?
Yep.
I'm so bad at maths. So does that mean we've got another one of these before the exam? We do.
Yeah, I think so.
Excellent.
Yeah.
Okay. Do you want to just do the same again? Is this helpful or is it stressful?
That was so helpful. It's so easy just to kind of get bogged down in like even though you know stuff, getting bogged down in like the later parts of the answer.
Yeah.
So like exactly what you said, stabilization, pain relief,
yeah,
things like history, minimum database, and
yeah,
physical examination. Like I could so miss that.
Yeah, history, physical examination, minimum database. Yeah, just do a like recite it in your head and then get into the detail. If anybody does want to do a private practical exam or oral exam, because obviously this is very full on, doing it in a group, Liz has prepared one as well, and she's really happy for anybody to approach her about doing a practice oral exam just one-on-one over Zoom. So she's got an exam ready to go for membership level. So Josh, you've got to do it, sorry. But anybody else who wants to have a practice in a private low pressure setting, Liz is open to it. And we might do the same again in 2 weeks' time if everybody's happy with that. And I will do ECGs next time, I promise.
Thanks, that was really useful.
Yeah, thank you so much.
Yeah, no worries at all. Thanks.
Anna, I'm mentoring a student. Would it be okay if I gave her the link to join in on the next one?
Oh yeah, of course. Jeff, anyone's welcome, really. Yeah, anytime. Totally fine.
The other thing I'd add to oral exams is work for me anyway, is to go in with the mental attitude that, right, I know my stuff and you're not going to catch me.
Do you know?
Rather than, because it can be so easy to be too nervous, but if you psych yourself up to thinking, right, this is a challenge, I'm ready for it, I'll let you have it back. And in my fellowship orals, they asked me a question in the morning that I couldn't quite fathom And then in the afternoon, they asked another one that was a little bit related. And then at least I was able to relate back that, yeah, that's what you were getting at this morning. So that you know, that went in with the mental attitude of, right, you're not going to catch me. I'm up to it. You know, you can,
we had a like for residents, like we called it the medicine masterclass, and once a year we just had this meeting, and one year we got an exam psychologist to speak at it, and he said that you should, before an exam, you should look in the mirror and you should posture like a silverback gorilla, like you put your shoulders back, you flex your muscles, and literally, like, there's studies and studies on it. If you look in the mirror and do a power pose before an oral exam, you'll do better than if you walk in going, oh, I'm so scared. So even if you feel like a dickhead, flex your muscles in the mirror before you go into your exam.
That's hilarious. That's gold.
Yeah, really interesting. Like, if you feel strong and powerful, like, the other thing he said is that you can lose 30% of your marks from anxiety alone. Like, no matter how much you know, if you can't get it out in an exam situation, like 30% you're below pass mark in the fellowship. Like, even if you knew every single detail, you're below pass mark. So you just can't afford to let anxiety get to you. So anything you can do to address that, you're helping your study. So definitely don't underestimate it.
Anna, just quickly, going back to the kidney with congestive heart failure and the radiographs, is it worthwhile describing what is normal as well? For instance, if I could say, you know, we were all thinking this cat had a pleural effusion, but actually on the radiographs, we didn't see any support of a pleural effusion. Is that
absolutely? So I think it's definitely worth saying in an oral exam, because as much as, like, as an examiner, you have an answer key and you can only give marks for things that are mentioned or not mentioned, right? So, like, there's 8 marks. So I can't give a mark for saying there is no pleural effusion, but if you've clearly demonstrated that you have interpreted the radiograph accurately by saying those extra things, if you're kind of on the cusp and say something slightly worded wrong, they're going to give you the mark. Whereas if you've kind of fence sat right up to that point, they won't give you the mark.
Yeah.
You know what I mean? Okay. So there's always that little bit of subjectivity, and anything that you say that demonstrates your understanding is going to add to their confidence in you.
Yeah, that makes sense. Yeah. Okay, that's great. Thank you.
Are you sitting exams, Alison?
No, I'm getting students ready for exams.
I was going to say, you've done yours, haven't you?
Yes.
Yeah.
But it's always good to know. And, you know, it's something that, you know, when I did memberships, we didn't have this valuable resource of going, what is it that examiners want? And so it's really nice to hear it from the other side. And I'm sure, you know, I'll sit some more in the future. So it's really good to know. Thank you. I appreciate it.
No worries. And they will, like, you know, we talked about those easy marks and things. The examiners know you know that. They will prompt you to say that if you've, like, clearly missed out on easy marks. So it's just good to get into that routine of history, physical exam, minimum database, and then get the ball rolling kind of thing.
Yeah, absolutely. No, it's great. Thank you. And it's good to be back. I've been a huge teaching load recently, so I haven't been able to make rounds. So it's really lovely being back. Thank you.
It's very nice to have you. Thanks for coming.
Thank you. Thanks. Ciao.
Ciao. See you guys.
Thank you. Bye.
Bye.